I'm gonna present my second presentation from this session. Managing a case with multifocal IOL in the setting of intraoperative complications such as posterior capsule rupture, which you will be seeing at PCR. The 74-year-old lady came for cataract in both eyes, not wanting to wear glasses anymore. The right eye was dominant, and these are the visual acuities, best corrected, uncorrected, and best corrected. The left eye is non-dominant. Again, there's 0.3 best corrected visual acuity. She presented with nuclear cataract, no other significant findings. And the recommendation was for femtosecond laser-assisted cataract surgery and trifocal IOL Panoptix, which is my preferred presbyopic IOL, especially after 55, 60 years old. And the femtolaser technology was chosen by the patient, but also I can recommend it sometimes when the pupil is large enough or in other cases. It's not a topic of this presentation, so I'm gonna be faster. The first surgery was in left eye and it was uneventful. The second surgery was the next day in the right eye, but I had a posterior capsule rupture, and you will see it was originating from the anterior capsulotomy run out. Please, if you can start with the video for me, please. So this was a nuclear cataract. The femto part of surgery went pretty much well. I didn't notice anything out of order. The phaco itself went okay, quite a hard nucleus, but I managed to do it very well. I had 8 pieces of radial pieces of nucleus, and everything was fine. I'm working on 2.2 incision, is my standard technique, on the steepest axis, especially in presbyopic lenses. And I was now preparing to change the instrument with a bimanual irrigation aspiration cannulas, and you will see how it's happening. So I was not even in the anterior chamber with any instruments, and later on I was able to see that the rupture started from the anterior capsular axis. It is very frustrating because it was done with a femtolaser, which is an expensive technology, and you want to trust it. And I was sure that if I would have done it with my own hand, maybe all this thing didn't happen. At this point, I decided, because the other eye had Panoptix one day before, I decided to implant, however, a Panoptix IOL. And for the sake of the safety and for safety reasons, I preferred to enlarge the incisions to suture it. I know you're gonna be, maybe I'll mess up the K readings and the astigmatism, but I prefer to have a safe implantation instead of having lost in the vitreous. And maybe with the astigmatism and sutures on the incisions, I will deal later. And this is what I was done, as a matter of fact. So my IOL is now completely in sulcus, because I have CCC, anterior CCC runoff. I was not able, and it was not possible to perform an optic capture. And I sutured the 6mm incisions with the 3 separate nylon sutures. And when I implant, anytime when I have posterior capsule rupture and it's a longitudinal shape, I prefer to implant the IOL perpendicular on the rupture, both on the anterior capsule rupture and the posterior capsule rupture. Of course, I was asking myself, should I implant it? Will it remain stable? Will it determine chronic iritis or inflammation and high IOP, which hopefully they will be transient and treatable. And indeed, you can see here better with the blue arrows the CCC run out at 8 o'clock, and with the red arrows the posterior capsule rupture. These are pictures from the video. And the early post-op follow-up was not that good in terms of IOP and in terms of astigmatism. Of course, my patient had 0.5 diopters of cylinder with the real astigmatism due to the sutures. But the IOL was well positioned in sulcus, well centered to the pupil, and the IOP was high, but it responded quite well to local treatment and acetazolamide for a few days. After 3 months, my patient came with a spherical equivalent of 0.5 plus. The cylinder is small, minus 0.5. And why was that? Because I started to remove the sutures step by step at starting with 4 weeks, not earlier, 4 weeks post-op. At 6 months post-op, the IOP is very well, with no treatment. The IOL is well positioned in sulcus, so for the moment it was still stable. The visual acuity was very good, and the patient was very happy. Now she has 1.5 years, and the things are doing very well. She's happy, she's still happy. What you see here written in hand, 1FC, means 20/20 plano in both eyes. So in conclusion, trifocal single-piece Panoptix IOL works quite well, or can work well, in PCR cases with no posterior capsule support, implanted in sulcus with no optic capture if it's not possible to obtain an optic capture. Because it is more controllable and safer, unfolded implantation can be considered when you have anterior CCC run out associated with PCR by enlarging the main incision at 6 mm, either at limbus, but it needs several sutures, or scleral, most posterior, but in this case 1-2 sutures can be enough, or even at all. You can expect post-op transitory complications such as high IOP needing treatment and high astigmatism needing step-by-step suture removal. Thank you.